An elderly woman walks into the hospital confused, drowsy, and unable to recognize her own medications. Everyone suspects dementia. Some think even it is a stroke, but the real culprit is sitting quietly inside her medicine box. And here's the frightening part. This happens every single day in clinical practice, and most students miss it in exams. Mrs. Sharma was prescribed multiple common drugs. Individually, each looked safe. Together, they created a hidden pharmacological disaster inside her brain. This is a silent danger of anticholinergic burden in geriatric polypharmacy, a high yield clinical concept for MBBS, NEET PG, and real world medicine. By the end of this lecture, you will never look on elderly prescriptions the same way. Welcome to our channel. Meet Mrs. Kamla Sharma, 71 years old. For last 3 days, her family has noticed sudden confusion, disorientation, and difficulty passing urine. Now, pause for a moment and think clinically. An elderly patient with acute confusion can mean dangerous things: stroke, sepsis, metabolic encephalopathy, even drug toxicity. But look carefully at the clues. Her pulse is stable, blood pressure is maintained, there is no immediate hemodynamic collapse. And then comes the detail most students ignore: urinary retention. That single symptom should immediately trigger one pharmacology concept in your mind. Because in geriatrics, confusion plus urinary retention often does not just a disease. It's a medication side effect hiding in plain silence. Now, the mystery starts unfolding. At first glance, Mrs. Sharma's prescription looks completely routine. Hypertension medications, diabetes treatment, acid suppression, nothing alarming. But in geriatric pharmacology, danger is rarely caused by one drug alone. It is the combination that creates the catastrophe. Look carefully at the last two medicines: oxybutynin, a strong anticholinergic used for overactive bladder; promethazine, commonly prescribed for sleep, allergy, or nausea, but also heavily anticholinergic. Individually, these drugs may seem harmless. Together, in an elderly brain already vulnerable to low acetyl reverse, they create what I call a chemical collision. And suddenly, the clinical picture makes sense: confusion, sedation, urinary retention, and cognitive decline. This is anticholinergic burden, one of the most underdiagnosed medication toxicities in elderly patients. And for exams, the key is simple. When an elderly patient comes and becomes acutely confused, always review the medication list before labeling dementia. Okay, future doctors, pause here for a second. An elderly patient walks into emergency with confusion and urinary retention. Most people immediately jump to UTI, maybe even stroke. But what if the real culprit is hiding inside the prescription box itself? This is where clinical pharmacology becomes detective medicine. Look carefully at her medications. Two drugs here are silently working to overload the brain with anticholinergic effects. And if you miss this pattern in exams or in real life, the patient suffers. So before you lock your answer, ask yourself, are you treating the symptom or identifying the toxidrome? Drop your answer in the comments right now: A, B, or C. And trust me, the explanation in the next slide is something you will never forget for NEET PG. Now, this is where many clinicians and NEET PG aspirants make a dangerous mistake. Option A looks logical at first glance. Patient has urinary retention, put a catheter. Confused elderly patient, start antibiotics. Sounds safe, right? But this is called an iatrogenic cascade. When we treat a drug side effect with another intervention instead of removing the actual cause. Look at what happens step by step. First, the catheter temporarily relieves the retention, but then you expose an elderly patient to infection risk, hospital complication, and unnecessary antibiotics. And the worst part, the real culprit, the anticholinergic drug combination, is still sitting quietly in the medication chart. So the confusion continues, the delirium worsens, and suddenly one prescribing mistake becomes a chain of reaction of medical harm. This is a classic pharmacological trap. If you don't recognize the toxidrome, you will end up treating side effects instead of treating the patients. And that single concept is extremely high yield for exams and even more important in real clinical practice. And here comes the real clinical thinking moment. Option B is the correct answer because it treats the root cause, not just the symptoms. Mrs. Sharma is showing a classic anticholinergic toxidrome, confusion, urinary retention, elderly age, and two high risk drugs working together. First, stop oxybutynin. This drug is useful for overactive bladder, but in older adults, it can strongly block acetylcholine and trigger the delirium. Second, stop promethazine. Many students forget this, but promethazine also has powerful anticholinergic properties. Combine the two, and the brain basically goes into chemical fog. Next step, hydration and supportive care. Give IV fluids, monitor the vitals, and allow the anticholinergic burden to gradually wash out. And the most satisfying part, once the offending drugs are removed, cognition often improves dramatically within 24 to 48 hours. That's the beauty of good pharmacology. You don't always need more treatment, but sometimes the smartest treatment is stopping the wrong drugs. And for NEET PG, remember this golden rule. An elderly patient with confusion plus urinary retention should always make you think, could this be an anticholinergic toxidrome? So, this is the part that separates memorizing pharmacology from actually practicing safe pharmacology. Stopping the harmful drugs is important, but replacing them intelligently, that's where the real clinical reasoning begins. Let's start with oxybutynin. It is a non selective muscarinic blocker, yet it helps overactive bladder. But in elderly patients, it also blocks acetylcholine in the brain, leading to confusion, delirium, constipation, dry mouth, and urinary retention. So, what's the smarter alternative? Mirabegron. Instead of blocking acetylcholine, Mirabegron works as a beta 3 agonist. It relaxes the bladder without adding anticholinergic burden. So, this is a favorite NEET PG concept. Same symptom control but safer pharmacology. Now, look at promethazine. Many people casually prescribe it for sleep or nausea. But in geriatrics, promethazine can be a hidden disaster because of its strong anticholinergic activity. So, a safer option is a low dose melatonin. Why? Because melatonin improves sleep regulation without clouding cognition or worsening delirium risk. And this is the golden clinical lesson. In elderly patients, every drug choice matters. Don't just ask, will this drug work? Ask, will this drug quietly harm the brain or not? That single mindset can prevent massive prescribing errors, both in exams and in real wards. Now, let's talk about one of the most underrated concepts in geriatric pharmacology, the anticholinergic burden score or ACB score. Because in elderly patients, toxicity often doesn't come from one drug, it comes from accumulation. Each medication adds a little more muscarinic blockade until suddenly the brain can't compensate anymore. Think of it like filling a bucket drop by drop. One day, the bucket overflows and the patient presents with confusion, delirium, falls, urinary retention, or even hallucinations. And here's how the scoring works. Score 1. Drugs have weak anticholinergic effects. Things like ranitidine or digoxin may contribute mildly. Score 2. Drugs have moderate activity. Oxybutynin is a major example. And score 3 drugs. These are heavy hitters, powerful anticholinergic agents like promethazine and amitriptyline. Now, watch what happens in Mrs. Sharma case. Oxybutynin gives her a score of 2 and promethazine adds another 3. Total ACB score is 5. This is deep inside the toxic range. And this is a clinical poll. Even if each drug seems acceptable individually, the combination may become dangerous. This concept is extremely important and honestly for every future doctor treating the elderly patients because polypharmacy doesn't just increase the pill count, it increases the hidden pharmacologic toxicity. Now, here is the scary part, everyone. This is not just a little confusion. A high anticholinergic burden score can affect almost every organ system in the body. Mrs. Sharma's brain is already showing delirium and acute confusion. Her bladder, urinary retention, her eyes and mouth, dryness and blurred vision. Her heart may respond with tachycardia, and her mobility, increased falls and gait instability. One of the biggest reasons elderly patients land in the hospital, and this is why anticholinergic toxicity is called a toxidrome because it creates a predictable cluster of symptoms across the entire body. For exams, remember this classic pattern: confused, dry, can't pee, can't see. The clinical lesson here is simple but powerful. When multiple anticholinergic drugs combine, the toxicity becomes cumulative, and the elderly brain is often the first organ to suffer. And finally, this is where clinical pharmacology becomes evidence based medicine. The AGS Beers Criteria is considered one of the most important safety references in geriatric prescribing worldwide. If an elderly patient suddenly develops confusion, delirium, falls, or urinary retention, one of the first things you should review is the medication list. And here's the golden rule: never combine multiple anticholinergic drugs in older adults unless absolutely necessary, because individually these drugs may look harmless, but together they can silently push the patient into toxic delirium. This is exactly why ACB calculators and medication reviews are now strongly recommended in every patient above 65 years presenting with acute confusion. So, the real diagnosis in Mrs. Sharma was not infection, not stroke, it was prescribing toxicity hiding in plain sight. And that is a power of clinical reasoning. Alright, NEET PG aspirants, this is the slide you revise one night before the exam. First, high yield point. An ACB score more than 3 in an elderly patient is a massive red flag for anticholinergic toxicity. Second, memorize this association: oxybutynin plus antihistamines like promethazine equals classic anticholinergic toxidrome. Third, the safer alternative for overactive bladder in elderly patients is Mirabegron, a beta 3 agonist. Is an extremely popular one liner in pharmacology MCQs. And finally, if the exam gives you an elderly patient with confusion, urinary retention, dry mouth, blurred vision, and multiple medication, do not jump to infection immediately. Think drugs, think cumulative toxicity, and think the anticholinergic burden. Because in NEET PG, the examiner is not testing memory alone. They are testing whether you can recognize a prescribing trap before it harms the patient. So, before you prescribe the next medication in an elderly patient, pause for one important question: what is the total anticholinergic burden now? Because sometimes the most dangerous drug is one added at the last. Thank you for watching. If this lecture helped you understand the anticholinergic burden and geriatric pharmacology more clearly, don't forget to like, subscribe, and turn on the notifications for more high yield clinical case discussions. Every week, we break down real exam oriented cases designed for MBBS students, NEET PG aspirants, and future clinicians. Remember, great doctors don't just treat symptoms, they identify the hidden costs behind them. Keep learning, keep thinking clinically, and keep prescribing safely. See you in the next lecture.